Lucy, I think you can go ahead with the introduction. We already have a good showing, and people can just trickle in. So yeah, I think we can get started with the introductions. And thank you for this very inspiring and interesting rounds. I'm looking forward to hearing your presentation.
So I'll say a couple of sentences about the nature of this presentation and then about Reitan himself. So thank you, Melina, and thank you, Dr. Feldman, for allowing Dr. Reitan Ribeiro to do this presentation, because the topic he's going to talk about is about fertility preservation in young women with cancer. And in the 35 years that I have been practicing, there's one sentence that sets off tears, even in a 65-year-old. And it is when we take a history and and they say they don't have children. I ask them, is it from choice, or is it, did this happen? And if it is not from choice, they start crying even at X number of years later, because having a biological child is something that is innate in them. We're grateful to Dr. Ribeiro because he recognized that and came up with a procedure that is new. Nobody would have thought of it, that allows young women who need pelvic radiation for a cancer to have their own biological child. And he'll explain all that, why. So thank you so much, Melina. Thank you, Dr. Feldman, for having the Department of Surgery hear this, so that it can spark off innovation among your team, and it can allow people to be referred during the window of opportunity where they can be helped. So, two sentences about Dr. Ribeiro. He's the only person, I think, in Canada who is dual certified. He is a surgical oncologist. He did his general surgery training, surgical oncology training, and then thought enough about cancers affecting women to do another fellowship in gynecological oncology. He came to us from Brazil. I heard about him almost for 4 years in every international meeting in Europe, in US, about his extraordinary surgical innovative skills. And he is being recognized this year at the International Society of Gynecological Oncology as the outstanding achievement in gynecological oncology surgery. So, Dr. Ribeiro, it's all yours now.
Okay, thank you. Thank you so much, Dr. Gilbert, for your kind words as usual. So thank you so much also to the Department of Surgery. It's an honor to join you and talk a little bit about something that is so important as fertility preservation. And I think as gyne-onc, we have this special connection, and I'm quite sure you all will see how we see it. And I know most of you are also very interested in preserving fertility, because quality of life now it's getting even more important than before. So obviously I'm going to use rectal cancer as a model, but it also works for other tumors. It's not just rectal cancer, but pretty much all pelvic tumors. So I don't have disclosures for this particular presentation. I'm going to show a bunch of pictures, patients' pictures, TV shows even, and this is all being consented by patients. So just going through some background, causes of infertility due to the treatment, what are the traditional options we have, what's uterine transposition, the results, and some conclusions. So first, we know patients are getting their first pregnancy later, usually in the 80s. They were around the 20s. Now they are going towards the 30s. And even in Canada, most of women, they have their first child after 30s, in the 30s. And also at the same time, what we see is an increase in cancer cases in young patients throughout all the even teenagers in the early 20s, 30s. So we have those two factors running along, and then we are seeing more and more patients with infertility and cancer. And when you think about it, sometimes we are just focused on treating cancer, and we forget like almost half of the women with cancer in reproductive age, they will lose their fertility due to the treatment. And it's very interesting because for rectal cancer, for instance, more than half of the patients, they report they've never been offered fertility preservation. So we need to embrace this and start talking with the patients, because one of the things Dr. Gilbert mentioned is for lots of people, having a family, having like a child, it's their main goal through life. So we cannot forget this. Sometimes as doctors, we are just focused on treating the disease. And when you look to all the treatment options we have, all of them might cause infertility for different reasons. Probably chemo is one of the most relevant, and also it's mainly because of breast cancer, actually, because it happens in young patients. And some of the drugs that we use for breast cancer, they can cause infertility, but most of the patients, they will get just temporary amenorrhea, and they will go back to have cycles, and they will have kids. And sometimes we don't explain them that that's going to be probably temporary. And most of the people that get chemo nowadays in modern systemic treatments, they don't have a real impact on their fertility in the long run. They may go through amenorrhea for a few months, but most of them will recover. And that's because during chemo, in the granulosa cells and other cells of the ovary, they get dormant, so they don't work. The cycles are interrupted, and the patients, they can't have, most of the time, they can't have get pregnant during chemo. But trust me, sometimes it happens. So we need to explain to patients that might happen. And some drugs, they cause more infertility. You don't need to know these drugs. It's just a general view. But I would say when we talk about rectal cancer, in general, chemo for rectal cancer doesn't cause infertility. So those patients may go through amenorrhea, but they will preserve their ovarian function, or chemo is not a major issue when you're treating young patients with chemo. We also need to remember that those patients that have, technically speaking, anatomically intact reproductive system, which means they can get pregnant, they have uterus, ovaries, tubes, they lost some reserve, but they still can get pregnant. They can go through IVF and all that. So what are the options we have to try to preserve fertility for those patients? Usually we can try analogs. This is pretty much letting the ovaries sleep throughout the treatment, throughout chemo. There is mixed results. We don't know if it really works. Sometimes we do, but in the end, results are very, very weak. And in general, what we do is embryo cryopreservation or oocyte vitrification. However, despite of being available, it's a good technique. But we need to remember it does not guarantee that you can have a child after getting some eggs frozen. And when we look on the bottom line, the chances of getting an oocyte to become a child, it's around 5 to 12%. So, and this is the data, recent data from big center, high quality centers. And even recent meta-analysis showed that live birth after oocyte vitrification is of the patients, between 26 and 32% of them will actually have a baby. So we need to remember it's not a guarantee, and it works. And this is for all patients, even patients with benign diseases. Another option is ovarian cryopreservation, something that we are doing more and more, is remove pieces of the ovaries. But usually we use it for patients that cannot wait for treatment. So there's like leukemias and other things, or patients underage patients, because they cannot retrieve eggs, or you cannot do stimulations if they are, child and young patients. And the good thing is you can just remove a piece, that's one option, and reimplant this tissue back to the patient later on, and they will resume or not just hormonal function, but they can also get their oocytes retrieval. So that's a good option, especially in patients, pre-teenager and young patients. So this is the curves of the FSH, which is like the hormone related to estrogen and all the production. So you see it drops in 6 months in patients that preserve tissue, they can go back to normal levels once you reimplant. The problem is when you look at your graph on the right, it's around the 10% of patients that do it will actually have babies. Well, there's also the surgical causes related to the infertility, like when you remove tubes, ovaries, or hysterectomy. We are doing, usually in a rectal cancer, unless there is direct infiltration, you don't remove those organs. But it's important to remember during surgery, you may damage those organs. And if you remove the uterus, the only option we have now is transplant. But it's important to remember that the transplant is a complex procedure. You still most of the time we use living donors, so there's the donors complications because of the surgery, because you just don't remove the uterus, you need to remove the vascular part of the uterus, and there are some damage related to this part of the procedure. Patients also need to go through immune system suppression, which causes also some complications. And usually they don't recommend to do transplant in cancer patients. So it's actually very, very experimental, and we don't use in a regular basis. This is just the corticosteroids effect to show this is the patients who got the first baby after a uterine transplant. And in the end, we still have radiation, which is one of the major causes of infertility in women. And it happens because when you radiate the pelvis, I'm going to show a short video about it. In patients with rectal cancer, radiotherapy may be used with curative intent. However, the scatter effect of radiotherapy spreads all across the pelvis. In female patients, this includes particularly the uterus, ovaries, and tubes. This scattered radiation is sufficient to cause ovarian failure, endometrial atrophy, vascular damage, and fibrosis to the myometrium, all of which ultimately cause definitive infertility. So, and that's the main issue with radiation, especially, and it can happen with any tumor within the pelvis, let's say even some sarcomas or even some bone tumors. If you need radiation, depending on the dose you use, you cause infertility, and even very, very low doses. So as low as 5 grays. It takes a while. It's not like immediate, but over the time, let's say if you get a 20 years old patient and you do like 20 grays at the ovary, in a few years, she lose entirely her fertility. So that's what happens to the patients. So, and now so it's not just ovarian function, also fibrosis of the uterus, the tubes stop working. So those patients, they cannot get pregnant. Even if you use IVF and other techniques, they cannot get pregnant. So now I'm going to show you how patients feel about it. And I just want to, and it goes back to what Dr. Gilbert was saying, that, fertility is a major thing for most patients. And some patients, their purpose of life is having kids. So I'm going to show you a few patients and how they felt when they had the diagnosis of cancer and they would lose their fertility.
O mesmo aconteceu com Franciele. Ela precisava tratar um câncer no reto, parte do intestino grosso. Na época, ela se preparava para ser mãe e viu seu sonho ir embora.
Eu ia perder o útero, eu não ia poder ser mãe com 26 anos, tipo, na flor da idade.
And this is another issue because most of those patients, they are young. They're not even planning to have kids anytime soon. So you need to plan in the long run. It's not just about, preserving fertility now. And that's why the options we have, they are not ideal because you can have frozen embryos, you can have oocyte vitrification, or you can have ovarian cryopreservation and all that. The problem is they are all expensive techniques. I know in Canada that's not an issue, but most of the countries that's an issue. There is also a delay for treatment because you need to give hormones, you need to retrieve the eggs. Sometimes you need to wait for the ovaries to go back to normal because they get very big during stimulation. Then you need to wait for them to go back to normal. So it's going to be around 1 month, 1 month and a half, maybe sometimes 2 months until patients get their all sites eggs retrieved, and then they can start treatment. And one of the issues is sometimes, ideally, you want to preserve embryos because the rate of successfully pregnancy with oocytes is much lower, much smaller than when you have embryos. But you need a partner. And if the patients, they froze embryos and the partner leaves, they cannot use the embryos. Most of the countries won't allow it. And in the end, because of the uterine fibrosis and the myometrial damage and the tubes and all that, even if you have the eggs or if you have the embryos, they cannot get pregnant because the uterus, it's not a safe environment. There are some reports of pregnancy and even deliveries, but most of the time that's dramatic. Most of the patients will lose the babies during pregnancy, will have abortion. And usually the results are not that good. So it's not a real option if they want to get pregnant. And the problem with that is sometimes you offer those techniques like in vitro fertilization and all that, but when they know they will need a surrogacy uterus, they just give up. Most of the patients won't do it. So how do we help those patients? So the uterus has one unique configuration which allows us to mobilize the uterus to the upper abdomen.
The vascular supply of the uterus offers a potential opportunity.
So what we do is we can ligate the uterine arteries. We can dissect the infundibulopelvic ligament, which is ligament containing the gonadal vessels. So the uterus can be mobilized to the upper abdomen. And then patients can go through radiation and preserve their reproductive function. So you can spare uterus, tubes, and ovaries from radiation. They can do the treatment, and then we can replace it back. So that's what we call uterine transposition. So this is the first patient. So after getting consent from all the instances in Brazil in 2015, this is the patient explaining how she felt about it.
Foi quando médico sugeriu a ela uma alternativa inédita, procedimento experimental chamado transposição uterina.
Se é para ter uma esperança de eu ter um filho e também dar esperança para outras mulheres ter filho, vamos fazer.
So I'm going to quickly show you how the procedure is done. I know not everyone is familiar with the anatomy, but I will try to explain. It's not hard, actually. It's quite easy. So there are two parts of the procedure. First, you want to mobilize the uterus to the upper abdomen, then you want to give radiation, then place it back. So for those who already saw a hysterectomy, it's very, very similar to a hysterectomy. That's how we place trocars. If you are going to operate with your colorectal surgeon, your colleague, you can add other trocars. That's not a major issue. And now we are using also robotic platform. So even the setting for rectal cancer, left column can work with this procedure too, if you need to combine the procedures. Okay. So you can see this is the rectal tumor. It's close to the sacral ligament. And then we are doing pretty much like a simple hist. We just mobilizing around the uterus. Yeah, sorry, there's one mic on. It's Dr. Sahil. Anyway, so we are just detaching the bladder. We are going around the cervix. You see, this is the uterus sacral ligament. This is posterior, and there is some adhesion. So we are leaving the tumor to get radiation. This is the uterine vessels being ligated. So we are ligating the uterine vessels. Then we just need to open the vagina and mobilize the uterus. So this is the right uterine vessels. We are opening the vagina now. You see the posterior opening of the vagina. And then we can mobilize the uterus with tubes and ovaries to the upper abdomen, and then we just close the vagina. Usually we wait and like 30 days to start radiation, but we realize that we don't need to, and we do 2 layers of suture, and those patients, they can start radiation in 1 week. So you don't need to delay radiation. And this is more than enough to make them go through simulation and now the planning required to radiotherapy. So they don't delay their treatment when you compare to standard patients. You just need to offer surgery right away, which we are doing now. So, okay. Then once you mobilize from the pelvis, you want to dissect the gonadal vessels up to the close to the kidney on both sides, and that reminds retrosigmoidectomy when we used to do from lateral to medial dissection. Then we just lift the column and we dissect the gonadal vessels. You need to do it very gentle, and you want to keep all the tissue around the vessels, as we do in any flap, like even for breast or whatever. You always want to have this package with the vessels and all together. So you see, this is the right gonadal vessels, and we are dissecting up to like subcostal margin is enough, and then you can push the uterus to the upper abdomen, or pull it to the upper abdomen. And you can see, and actually, the uterus can reach the thorax if you want. It's very impressive how mobile those, and how those vessels are very long vessels. So, and now you see we just doing attaching the uterus to the anterior abdominal wall. We also do some stitches in the ovaries, so we make sure they are not mobile and they don't fall to the pelvis. And you can see we are placing those stitches at the subcostal margin. So this is so far from the radiation, from pelvic radiation, that the dose they get is less than 0.1 gray, which is pretty much nothing in terms of function. We do a bunch of sutures. We don't want to have an internal hernia. We just deflate the abdomen and then we pull it, because we don't want to cause traction while doing it. And usually we do it in a different way. This was the first case, I guess. We do sutures like transparietal sutures. The patients, they can, no, this wasn't the first case. And we used to do, and this is a more like historical part, we used to do an anastomosis of the cervix with the umbilicus. And the reason for that is because we could examine the patients after surgery to look for ischemia, because this is a flap. And also patients can have menses during the treatment. So you see, this is the cervix. We can check if perfusion is fine. We don't do it anymore. Now we use more Doppler ultrasound of the gonadal vessels. You can also use MRI to check perfusion. And then you can see this is the uterus and the cervix connected to the umbilicus. So you can, and now we can use the different techniques. But and this is the first time patient got a mens through the umbilicus. And I know it's weird, but it's a very good way of checking if everything is working. And the patients don't mind, trust me. Well, then they get radiation. Now it's time to place the uterus back to the pelvis. It's pretty much the same setup, but you can use, if you're planning a retrosigmoidectomy to be done at the same time, you can use the trocars from general, the positioning from general surgery. They work as well, because it's more about detaching, just getting rid of some adhesions and then suturing the cervix back to the vagina and the ligaments. So it can be easily done. It just takes a while because there's lots of suturing, but other than that, it's not a very difficult procedure. You see the uterus coming back. And you can see this is going to be the retrosigmoidectomy being done, like usual. Say that it's not different from a traditional. And even when you think about the pelvis itself, it's even easier because you don't have the uterus in front of you while you're doing the retrosigmoidectomy. And we removed a small piece of the vagina where there was an adhesion, but in the final pathology for this patient, there was an invasion of the vagina in the end. But this is, post-neoadjuvant treatment. So this is the mesorectal resection. And then we are using staplers to the rectum. This is, every department will have a different approach. And just to show you how you have access to the pelvis, because most of the surgeons, they are concerned, how it's about the pelvis, or how are the adhesions after mobilizing the uterus? And it's it's not much actually. If you on the right plane, you don't see much adhesions. If you do like proper hemostasis, you should be fine. And then you see we just remove the scar tissue from the cervix, and we do the anastomosis of the cervix with the vagina as like say anatomically normal cervix. And this is how the cervix looks like. In the end of the procedure, we just reconstruct the ligaments. I like to use Proline because there is not much inflammation. So when we go back, let's say this is the final aspect of the surgery, and usually we test the tubes just to make sure they're working. And when you look at the pelvis after the retrosigmoidectomy, it looks quite all right. And this is when we were removing the ileostomy, and this is the cervix 6 weeks after reimplantation. So I would say it's quite close to the normal ones, normal patient. Those are some patients with menses in the umbilicus. Trust me, they don't mind. They are so focused on treating their cancer and preserving fertility. But anyways, nowadays we don't do it anymore. Now we give analogs and we leave the cervix inside the abdomen because we now very confident it's not an issue as it was before. Also, lots of people, they ask me how it's patient's life with the uterus in the upper abdomen. And this is a Facebook picture that the patient posted 15 days after surgery. Obviously, I called her back and I said, why are you doing this? But anyway, she was feeling great. And most of the patients, they feel quite all right. 15 days, even with the uterus in the upper abdomen, is not a major issue. They can have a quite normal life, I would say. This was published in 2017. We got approval for a prospective feasibility trial back then, and I'm going to show you about the feasibility trial results, so we can discuss also. Main indications: rectal cancer, canal anal, pelvic sarcoma, and other non-gynecological tumors. That was the indication. Obviously, when you're doing a feasibility trial, you want to know if it's safe and if you can preserve the uterus, because evaluating fertility, it's much harder, takes much longer. Some of those patients were like 18 years old, so they won't get pregnant or try to in the future, let's say for 10 years, sometimes 15 years. So you need a very wide, very long follow-up to evaluate fertility. Anyway, so the primary objective was, is it safe? Can we really preserve the uterus? Because if I'm doing all that, the patients are losing the uterus, doesn't make any sense. And also hormonal function, quality of life, and surgical complications. All those patients, they go through history of infertility. Obviously, you don't want to do this kind of surgery in a patient that have lost one of her ovaries or that get any kind of infertility. They go through genetic counseling. We always offer frozen embryos and oocyte vitrification. But if you preserve the uterus and ovaries, you can also do those procedures after. So, but we try to offer both. So we want to combine everything we have to give the best option to the patient. And we just use routine imaging as we do for all cancer patients. And one of the discussions was, especially in Brazil, it's a poor country. So while we were offering CAR-TC at the center, there was HIPAC. We are doing robotic surgery. And I was explaining that's going to be the cheapest option of fertility preservation, even compared to, in Canada, surgery is a bit more expensive. But in Brazil, comparing IVF techniques to surgery is much cheaper. And there is no, and IVF or fertility techniques are not available for the public health system. So the patients need to pay for it. And so the cost is quite not much. So you just need to laparoscopy and some training. So gyne-oncs in general, they are very familiar with all those, with this anatomy. So that's not an issue for center with the gyne-onc. Oh, did I miss one? Okay, yeah. Since then, other countries are doing, and I must acknowledge Mario Leitão from Memorial Sloan Kettering, because he's been one of the person that's been pushing the procedure. And They did their first case before Christmas. I think it was 5 years ago, and since they started doing it, it's helping to spread all across the globe, and and now in Canada too. So I'm going to show you some results, and then we can discuss. We have more patients, but these are just the patients that we did between July 27, June 2027, June 2019. We selected, there was 11 candidates, 3 of them refused the procedure. Mean age was 30 years. Median follow-up for this first publication was 30 months, so not much. And when we look to the results, most of the patients are rectal cancer, right? So there was a pelvic liposarcoma, but most of the patients were rectal cancer. Well, there were complications, especially ischemia of the tip of the uterus, but that wasn't much. You just need to remove this tissue afterwards. But one patient, and now we are not seeing it anymore because we are just leaving the uterus inside the abdomen. But what you might see when you leave the uterus inside the abdomen is this what we call like hematocolpus, which is like blood being encapsulated at the cervix. But despite of being ugly, let's say, it's not an issue. Just remove this tissue. There's just fibrosis, and it's not a major issue for the patient. It's more like a fibrosis around some bleeding that may happen. And however, one of the patients got a uterine necrosis, so that's the main concern about the surgery itself. You might lose it's a flap, so sometimes we lose the flap. But in the end, this patient, she preserved her ovary, so she still has normal hormonal function until today. So she's being followed and she's fine, but she lost her uterus. Anyways, if we left it in the pelvis, she would lose it, like functionally speaking anyways. So we need to consider that. So this is some images from the patient. And just to summarize briefly the results, all the patients included in the feasibility trial had normal hormonal function, which is very important in women in their 20s, 30s. And all of them had normal sexual life. This is very important because you don't want to cause any like a pain or things that may compromise sexual life. Unfortunately, we didn't plan to compare to the patients they just went through radiation, but that would be very nice to compare because one of the things when you take the uterus out of the radiation, it preserves its glands, so the patients have normal lubrication. It's different from a patient that irradiates with the uterus inside. They lose their glands, so they have no lubrication. So intercourse is much harder for the patients that irradiate with the uterus inside. And then the $1 million question is, okay, but in the end, do they preserve their fertility? And that's the main question, right? Because in the end, that's what you want. This is the patient talking about it. Oops, I have an issue with my...
Ano passado, já recuperada, veio uma surpresa.
Eu estava na minha recuperação. Quando eu vi que a minha menstruação atrasou, eu tô grávida. E agora?
Você fez quantos testes de gravidez em casa de farmácia?
Fiz esse baratinho, deu positivo. Eu falei, não, isso aqui tá errado, não pode ser.
Um bebê. Esse é o Nicolas, a primeira criança a nascer de uma mãe que fez a transposição de útero.
Foi uma emoção muito grande, assim. Eu sabia que meu filho ia vir com saúde, com vida. E quando eu vi ele vindo perfeitinho, assim, fiquei muito feliz.
So this was the first baby from uterine transposition, and for that cohort of 8 patients, 1 lost the uterus, 1 patient died from cancer. It's important. You need to know that some patients will die during treatment. Some patients will recur. We might have even a baby afterwards without the mom. So you need to deal with all those issues. But in the end, for the first time, we got a procedure that was able to allow those women to have children and spontaneously. None of those three of those patients tried to get pregnant. 2 of them got spontaneously pregnant with healthy babies. So we kept the whole, from sexual quality of life through having babies. We managed to keep. This is the first time. So those are the first 2 babies. And now, actually, this is updating data. Most of them are not published. Some of them are. But now we have babies in different countries, from Middle East to US in Latin America. Hopefully soon in Canada. And that's why the ASCO guideline update from 2023 included uterine transposition as one of the options. And when you take a look, obviously, uterine transposition is still an initial procedure. So you need to be careful. We can't make, we need more data, and we're still working on that. But when you take a look and compare to other procedures, at least in the beginning, if you compare to cryopreservation, that you can have like babies in half of the patients, and oocyte gratification maximum is 35. 35 is like top, right? And even ovarian transposition, when you don't mobilize the uterus, just mobilize the ovaries, you can still retrieve eggs and try to preserve their fertility. Well, so you need to consider that you can have babies in around 60%. And why 60? Because those are data from other trials, prospective data from other centers with uterine transposition. When you consider even miscarriage and ovarian function, all of the patients published with uterine transposition, they are keeping their ovary function. So you can combine those 2 things that are so important. And now we have the MUHC program. I'm just finished. I just need 2 minutes. We are offering uterine transposition for patients between 18 and 40 years old, non-gynecological pelvic tumors. So I know the use of radiation for rectal cancer is in decline, but there's still some cases we can use. And it's obviously depends also on the dose that we are expecting to reach ovaries and uterus. We need to work on that. Some patients, we might manage to spare those organs, but that's most of the case, that's not what happens, and they can't have any history of infertility. Well, in conclusion, I would say, first, patients undergoing oncological treatment frequently lose their fertility. We must be aware, and we must tell the patients that's an issue. They need to know, and they need to know the options they have. So this is very important. There are different good options. So I'm not saying uterine transposition is the best option. It works all the time. It's not that, but that's one of the options. They may have different options. They need to see a specialist, and it needs to be done in a timely manner. Uterine transposition is feasible with good initial results in terms of ovarian function and reproductive function preservation, and it's been offered at the MUHC. This is my email, phone number. If you see a patient, please let me know, and please help me to spread this message to other doctors. And finally, I must acknowledge this patient, because she was the first patient to get the procedure done, which obviously is very special.
Posição uterina também passou pelo tratamento de câncer e se recuperou. Ela quer ser mãe em breve. Hoje lembra com emoção daquele dia de 2015, quando aceitou ser pioneira do método que permitiu a Karen engravidar.
Eu não consigo. É gratificante. É gratificante. Que eu dei a chance para essa mulher, aí começou a fazer sentido tudo, sabe? Então, por isso que hoje eu só tenho gratidão.
And good news is this year this patient got pregnant. She's pregnant with twins. So thank you so much, and I'm happy to take any questions you might have.
Wow, thank you so much. This is really quite amazing. I don't know if can you hear me?
Yeah.
Yep.
Thank you so much.
So yeah, I don't know if anybody has any questions, if you want to put them in the chat, or I don't know if maybe Dr. Gilbert, do you want to moderate the questions or make any comments or anything?
I'll make
please,
a
feel free.
comment.
Yeah.
One comment, and then, but I'd like the surgical department, if you have questions to ask. What I wanted to say is we have joint appointments between the Department of Surgery and the Department of the Oncology Department, and I'd like to leverage that more because we've set up in the Department of Oncology a Center for Surgical Innovation, and Reitan has been appointed as the director because there are things that only surgeons can think of. You do it all the time, and you think, oh, maybe this may work, but there isn't a mechanism at the moment to allow you to explore those ideas. I'm extremely grateful to the Rossi Cancer Institute network because they gave Reitan applied for 100,000 and he won that competition, and that's what allowed him to set up this. But for surgical innovation that's not directly related perhaps to outcomes, but much more in the early phase, I'm working with the Center for Advancement at McGill and they have promised to work with to raise a significant amount of money, even in these hard times, that the Department of Surgery and the Department of Oncology can work together on these innovative techniques. So hopefully by next year, we'll have a sufficient pot of money to open up the competition. Thank you.
Thank you.
Thank you. I think there's a question from Dr. Stein. Do you want to pose it yourself, or do you want me to read it out?
Yeah, I just saw it. So that's an excellent point. Dr. Stein is commenting on pelvic adhesions. Yeah, there's always a risk of pelvic adhesions. This is a major cause of infertility. We don't know exactly the numbers, but it's very common when you go back to and try to see what's happening with those patients. They might have other causes of infertility. One of Dr. Stein teaches surgical technique. I would say one of the things that helped us to improve is because we are reoperating those patients, right? So we can notice how when you are technically very precise and you take care of hemostasis and you are on the right planes, you can avoid lots of adhesions. And if I have a bunch of videos I can show one day, the difference when you left blood somewhere and you come back, there's adhesions. And if you are very careful with the hemostasis, with the planes, when you go back, there are almost no adhesions. So, and preserving the embryological plane, so being in the right plane is very important. But, again, adhesions, that's going to be always a challenge. That might be an issue, indeed, we need to consider. And it's a very difficult one.
So no other questions. So you wowed them. Entire Department of Surgery doesn't have any questions.
I'm so happy.
So if there's no more questions and you're 8:15, maybe we can call it to a close. Thank you.
Yes, I think that would be fine. Have a good day, everybody, and thank you very much. I think we'll be probably sending you some patients soon, hopefully.
Hopefully. Thank you so much.
Thank you. Great talk.
Melina, thank you,
Thank you.
Dr. Feldman, for allowing him to speak. Thank you
so much.
That's great talk. Thank you so much.
Thank you,
Bye.
Dr. Feldman.